Thank you very much for the introduction, Dr. Delacose. And yes, today's topic is persistent depressive disorders in the responders who treat. And what I would like to be able to get across by the end of this presentation is why is it that we continue to see patients presenting with depressive symptoms when it's now more than 2 decades since they were exposed to psychological trauma? So, okay, I have no conflicts of interest. Um, I am going to start with a brief overview of psychological trauma exposure and associated conditions, and really focus on trauma-related depressive disorders. I'll talk a bit about how neurobiology um, of trauma contributes to chronic illness presentation and review some of the research findings within the 9/11 exposed cohort on prevalence, trajectory, and health burden of depression, and focus in on some of the risk factors and mediators of adverse health outcomes. And I'm going to end with what you can do to screen for depression and suicide risk. So we are all at this point very well familiar with the effects of the exposure of the World Trade Center terrorist attacks, the exposure to environmental toxins and psychological stressors was um, uh, incredibly large. There was, of course, the immediate risk to life that people experience and the losses, very suddenly losing co-workers or family members, the horrific events that they experienced, whether it was witnessing people falling and jumping from the towers or getting caught underneath rubble or in the dust cloud and being sure that they were never going to come out alive. There were other responders faced long hours under often very hazardous work conditions. And many of the responders, the non-traditional responders, actually had no training in disaster work and in some of the tasks that they were um, handling, such as recovery of body parts. We know that the community members lost their homes and their jobs, and many lived in disaster areas. And very importantly, this was not 1 week, 1 month. The response efforts continued for many months. Many individuals were present for weeks and months. We know the number of hours that they had in the exposure, and some of them are remarkable. So, there has been considerable research at this point documenting the relationship between the exposure and a number of psychiatric conditions. And these are the ones that I have listed here that are covered by the program because they are deemed to be associated with 9/11. Acute stress disorder is no longer diagnosed because one of the criteria for its diagnosis is that symptoms resolve within 1 month of the traumatic event. And that category may actually define the individuals who have, what we are trying to define are those resilience factors. PTSD is highly prevalent. It is a very serious, complex, difficult to treat condition and the most often diagnosed condition within our program. Anxiety disorders, agoraphobia, panic attacks, and substance use disorders are highly comorbid with the other conditions. And the topic of this talk, which is the depressive disorders, these are serious recurrent disorders. They are one of the most common illnesses worldwide and a leading cause of disability. Major depressive disorder is the most serious of these conditions. and associated with mortality from suicide. Um, we have dysthymia, and as it's now called in psychiatry, persistent depressive disorder, which really describes what it is, this chronic low-level depression. Um, and then the bottom two, adjustment disorder with depressed mood and medically associated depression, those diagnoses capture the individuals who develop clinically significant symptoms, depressive symptoms, in the context of a diagnosis with a serious medical condition or progression or treatment of that condition, which, as you know, can be quite severe. Now, I'm going to I'm going to describe the diagnostic criteria for major depressive disorder. Um, the criteria that you see here are common across the other depressive disorders, but I thought I'd just focus in on this one. It is a chronic recurrent illness, and it is, for the diagnosis, there are two core symptoms, and that would be persistent feelings of extreme sadness or marked loss of interest or pleasure, anhedonia. Those symptoms must be present for the diagnosis of major depression to be made. Then there are the associated factors, excessive guilt, feelings of worthlessness, helplessness, hopelessness is particularly important in indicating severity of illness. I'm sure you hear a lot of people who complain of problems with sleep, who overeat, who complain of fatigue. Cognitive complaints you hear a lot of, and that is a key symptom of depression. Psychomotor abnormalities, people who are fidgeting or people who just are very leaden and can't get up and do things. Of course, recurrent thoughts of suicide. Now, again, for the diagnosis, these symptoms have to cause some clinically significant distress or an impairment in function. And we need to make sure that you rule out other causes of these symptoms, such as substance use, opiate use causing these symptoms, or other medical conditions, whether it's Parkinson's disease or adrenal insufficiency or medications such as high-dose steroids, which have symptoms that may mimic what we see here. So especially in our population, it's important to make sure that you rule that out before considering major depression. Not that they're mutually exclusive, of course. Now, although the topic of today is the persistence of depressive symptoms, I do want to highlight that trauma exposure does not necessarily result in illness. When individuals encounter traumatic events, they are, of course, going to experience a whole range of emotions, including fear, sadness, feelings of guilt, severe anxiety, panic, and sometimes somatic symptoms, and those may last for a while. However, we do know from studies in disaster-exposed populations that emotional resilience is the most common response to trauma exposure. And in general, individuals cope well, and the acute stress symptoms typically resolve within weeks, as in I mentioned earlier, acute stress disorder. Nevertheless, exposure to disasters and major trauma is known to increase the risk of subsequent psychiatric disorders. And in our cohorts, there are psychiatric diagnoses are found in up to 25% of individuals. And there are a variety of risk and protective factors that I'll go into that affect the onset as well as the persistence of these symptoms. Okay, I'm going to briefly review the neurobiology of psychological trauma and how it contributes to persistence of symptoms. So this here is a schematic of the cascade of changes that may result from severe stress and trauma. We know that stress and trauma activates a physiologic response, leading to a cascade of systemic dysfunction mediated in large part by the hypothalamic pituitary adrenal system. So the schematic demonstrates here's stress coming in, here's the HPA system, and the dysregulation of neuroendocrine function, including cortisol, um, and also a disruption in the immune and inflammatory systems. It, the effects include neurotransmitter function and also affects areas of the brain that are implicated in a lot of trauma disorders, including the hippocampus, the amygdala, and various cortical regions. These in turn lead to autoimmune, cardiovascular, neurodegenerative, and of course, psychiatric conditions and affect mood, cognitive function, emotional regulation, including irritability and emotional outbursts, and behaviors such as social withdrawal or substance use. Now, one of the results of this neurobiological dysregulation is that it triggers a persistent um, biological distress or danger signal that tends to perpetuate the symptoms that we see in depression or other trauma disorders. It's as if that system that's turned on by the trauma exposure cannot be turned off in susceptible individuals, or it's very hard to dial it down so that patients continue to live with some of the symptoms that they had when they were exposed to the event. This is a quote that I really like by Dr. Bessel van der Kolk, who has done pioneering work in the area of trauma psychology that um, summarizes what I've just said in a far more eloquent manner. So I'll quote, trauma is much more than a story about something that happened long ago. The emotions and physical sensations that were imprinted during the trauma are experienced not as memories, but as disruptive physical reactions in the present. And that is actually what we see. Now, of course, the enduring effects of the health effects of 9/11 exposure are not limited to depression or to mental health conditions. And if you haven't taken a look at this online exhibition sponsored by the CDC on the health effects of 9/11, it's well worth taking a look at. It really was created to highlight the ongoing health, physical and mental health effects. Now, with respect to psychiatric conditions, um, there is a large body of literature at this point that supports the persistence of psychiatric symptoms up to 15 years post 9/11. We see depression in up to 18% of the combined responder and survivor cohort. PTSD prevalence really varies anywhere from 9 to 24%, depending on the studies. And I'll go into some of the reasons for that a little bit later. Alcohol misuse, 25% of responders described um, excessive alcohol use up to 10 years post 9/11 in a couple of the studies that I reviewed. And we also know that the trajectory of illness varies. So there's everything from recovery to partial recovery to chronic illness. You'll see symptoms that present early or that arise years later. In addition, there's fluctuation so that symptoms may worsen or resurface with future stressors or with medical conditions that arise years later. So, what are the drivers of these persistent symptoms? Well, we have 20 years of health effects research at this point, and that's helped to identify kind of a really complex combination of risk factors that mediate the broad range of mental health outcomes, including the duration of symptoms. And they include individual risk and resilience factors. So things like genetics, socioeconomic factors, um, prior psychiatric diagnosis, elements related to the exposure itself. And we do know from our cohorts that responders who have the highest level of exposure have the greatest risks for both physical and mental um, health disorders. However, I am going to focus on the following risk factors, and that is medical and psychiatric comorbidity as a risk factor for persistent illness, differences in responder occupation and associated training, social support, and then the many adversities that individuals have faced in the subsequent 20 years. Okay, I'm going to start with medical and psychiatric comorbidity. It's clear from many studies that the presence of coexisting medical and psychiatric conditions is the factor most strongly associated with illness chronicity and with functional impairment. And it's particularly important for our cohort because we know that about 60% of responders, general and FDNY responders, have at least one exposure-related health condition. Now, this figure here is from the General Responder Data Center, the annual health surveillance report from last year. And it shows the certification data for cancer, physical health conditions, excluding cancer, and in green, mental health certifications. And what really demonstrates is a significant overlap amongst these conditions. And indeed, 21% of our cohort is the responder cohort is certified with both physical and psychiatric illness. And this, of course, is going to lead to an overall greater health burden, increased medical complexity and symptom severity. There's going to be worse cognitive functioning associated with comorbidity, functional impairment, and it's going to be much harder to treat patients with comorbid conditions. So you're going to have worse treatment outcomes contributing to enduring illness. And highlighting the importance of the integrated screening and treatment that we offer within our program. Now, just as with medical conditions, the presence of coexisting psychiatric disorders also contributes to persistent illness and severity of illness. So PTSD, depression, and substance use disorders are highly comorbid. PTSD is a significant predictor of depression 15 years post 9/11. And depression has been found to be much more common among patients who also have PTSD. So 56% of patients with PTSD will also have a diagnosis of major depression. Um, those without a history of PTSD have far less incidence of depression, something around 5%. It's a big difference. We know that 25% of highly exposed responders report binge drinking 10 years post 9/11, and a lot of the reasons given are to deal with the persistent symptoms that they experience. So untreated illness is a major factor. And we also see elevated alcohol and drug-related mortality um, when there is psychiatric comorbidity. Now, this chart here is from a study, 2014, taking a look at comorbidity of depression and PTSD up to 11 years post 9/11. And it took a look at the number of poor mental health days over the prior 30 days and PTSD related impairment. The hatched line below are individuals who have PTSD with no depression. The line above it is PTSD plus depression. And it's clear to see that the additive effects that um, those individuals with both conditions had a far greater likelihood of impairment and poor health days. Now, medical comorbidity also contributes to the onset of depression many years later. So, when newly diagnosed with serious medical conditions or when facing the limitations imposed by worsening illness, some individuals may experience clinically significant depression or anxiety, and those are conditions that are diagnosed as adjustment disorders. Within the program, they're also identified as medically associated conditions. Um, this is particularly common. I've certainly seen this a lot in patients who are diagnosed with cancer yesterday. So someone who I diagnosed with an adjustment disorder. Um, because of the latency, we're going to see late onset depressive symptoms associated with the medical diagnosis. And pulmonary disease, such as COPD, as it progresses and people start to lose their function and their independence and have to be oxygen dependent, that is going to contribute to um, feelings of depression and may result in clinically significant depression. So it's important to identify these conditions, these depressive disorders. First of all, because we have so much comorbidity, but also because there is an increased risk of mortality by suicide in these individuals. Now, I'm going to move on to um, occupation as a risk factor, the mediating factor for illness, persistence of illness. So we know that the responder cohort comprises the traditional responders, presumably those who have some um, disaster training, and the non-traditional responders, as we refer to them, the cleanup, construction, sanitation workers, and the volunteers who presumably do not have um, training in disaster response. Um, and it's been found that differences in occupation and and training are significant risk factors for illness. This paper that came out in 2007 by Perry and colleagues was one of the first studies to compare workers from different occupations responding to the same disasters and took a look at the differences in PTSD prevalence. And they found that it differed substantially across occupations and was significantly higher among those who performed tasks not common for their occupation. So those who did not have disaster training specifically. The PTSD was diagnosed in 18% of the non-traditional responders compared to 6% of police responders. FDNY was not included in the study. And this all suggests that disaster preparedness training could be a protective factor in minimizing psychiatric morbidity in disaster work, highlighting the importance of providing workers with training, disaster preparedness training, which I know many of you do. And this includes not only physical preparedness training, such as wearing PPE, but also psychological safety education. What are some of what you can expect as emotional reactions? What's normal? What may not be normal and may need intervention? Now, suicide risk was also found to differ by occupation and training. This paper from a couple of years ago took a look at prevalence and correlates of suicidal ideation, and suicidal ideation is a key risk factor for suicide mortality in responders. And they found that it varied by occupation, so that they found suicidal ideation in 12% of non-traditional responders compared to 2% of police responders. Now, the average US adult population, about 5% reported um, suicidal ideation within the past year. So that 2% for police responders is questionable. And the theory is that there might be underreporting due to stigma and fear of negative job consequences within our program because this is not de-identified. And this is not monitoring data that was used for this study. Now, with respect to suicide mortality, there has been inconsistent findings. One longitudinal study found an elevated rate of suicide in non-traditional responders compared to survivors. And a more recent study from last year found that there was no excess mortality by suicide in a cohort of responders. So we clearly just need more studies. Now, in the years post 9/11, there have been a lot of additional losses, social and economic losses. This paper from 2016 by you and colleague took a look at the impact of 9/11 related chronic conditions and found that workers with chronic conditions were much more likely to experience early retirement and job loss. Not surprising, but important to document, and that the likelihood increased considerably when the worker also had PTSD. So, um, some of the downstream effects of the exposure and the illnesses related to the exposure included loss of work, loss of medical benefits, which increases barriers to care and leads to worse health outcomes. Very importantly, um, the healthy worker effect is lost when you lose your job. There's a loss of community cohesion and a loss of the worker identity, which is so important for mental health. And a lot of these elements also contributed to family losses, divorces, estrangement from children. There are a lot of reverberations beyond the trauma event. Subsequent trauma exposure. Populations with a history of trauma exposure, so that's going to include many of the individuals we treat, are going to be more vulnerable to adverse psychological consequences when they encounter subsequent traumas. And this contributes to enduring depressive or other illness symptoms. Um, and in fact, re-traumatization is an occupational hazard for responders and healthcare workers because it happens so frequently that they are exposed to potentially traumatic work-related events. We have also seen within our cohort exacerbation of psychiatric symptoms following disasters of all sorts. And during and following the COVID-19 epidemic, we saw a lot of re-experiencing of 9/11 trauma. Responders reported and survivors reported re-experiencing that was triggered by the constant silence that we also heard around 9/11. The refrigerated trucks, the lack of PPE, the fact that the air was unsafe in some way in both situations. So we had a lot of reactivation of symptoms. Now, most of the studies of disaster exposure have focused on pathological outcomes. However, there has been more work recently done on resilience and on what's called post-traumatic growth, um, positive effects that may occur following trauma exposure. And what's been noted is that there is a bidirectional effect between mental health outcomes and social support. So some of the factors that are associated with resilient trajectories include having social support available, especially when working on the response effort, and belonging to a community, including belonging to a work community, having a union um, uh, makes a difference. One recent study found that having at least one important source of social support was associated with fewer depression and anxiety many years later. Um, and that social support can come from family, community, or again, importantly, the work environment. There's a lot that can be done within the work environment that can support mental health and increase resilience, especially for individuals who are at risk for occupational trauma exposure. And in essence, social connectedness is an essential element of psychological health. We are social creatures and we thrive with social connectedness. So, all that said, I'm going to talk now about screening for depression in general medical settings, things that you can do. So, why should there be screening in medical settings? Why should you be doing this? Well, first of all, you've seen the prevalence and the comorbidity. So you're going to see patients who have depression, PTSD, anxiety disorders, and suicidal thoughts. We know from other studies that 50% of people who die by suicide actually see their primary care doctor within the month before their death. So there is an opportunity here for non-mental health providers to identify severe depressive illness and suicidality before there is a terrible outcome. We also know that management of conditions like depression is common and safe in non-psychiatric settings. It's done throughout the country very commonly. And there is an ongoing need reported in our cohort. Almost half are traditional responders and 20% of police responders expressed an unmet need for counseling and medication for um, depression and anxiety. So we have a need. And further, we have effective treatment. So the importance in identifying is so that we can actually treat the condition. Treatments are psychotherapy, which could be challenging due to the um, dearth of specialized providers who can provide psychotherapy. Um, Other pharmacologic treatment, antidepressants, um, are very effective and can be prescribed by most prescribers. And for treatment resistance, there's combination of treatment modalities that can be very effective. So, um, how do we screen? You're probably familiar with the PHQ-9, the Patient Health Questionnaire, which has 9 items. It's a very common screening tool in research as well as in clinical practices. And it consists of this series of questions that are rated from 0 to 3, not at all, or nearly every day. And it asks, over the past 2 weeks, have you been bothered by any of the following problems? And as you note, it starts with the key diagnostic criteria: little interest or pleasure in doing things, or feeling down, depressed, or hopeless. The other items follow along with the diagnostic criteria. Now, what happens if you get to question number 9 and the patient in front of you says, I have had thoughts that I would be better off dead just about every day. Um, and actually, I've been waking up and thinking about, how can I just do away with myself? What can I do to just end this misery? You may run into these situations. So what do you do at this point? Well, yeah, suicide is one of the most devastating consequences of mental illness. Um, and really highlighting the importance of knowing how to do a suicide risk assessment. The gold standard is what I'm showing here, the Columbia Suicide Severity Rating Scale. And it is a simple list of 6 questions that guides you, and it can be done by anyone. There's a robust evidence base in suicide prevention when this tool is used. And just going through it, you always ask questions number 1 and 2. Have you wished you were dead or wished you could go to sleep and not wake up? Or have you actually had some thoughts about killing yourself? And the instructions say, if yes to number 2, go on to the next 3 questions. Have you been thinking about how you might do this? Have you had these thoughts and intention on acting on them? Have you started to work out some plans on how you would do this? And then you ask question number 6, always, have you done anything or started to do anything uh, or prepared to end your life in some way? And it gives you the language, this tool gives you the language, and it gives you examples here, such as, did you have pills in your hand and then decided at the last moment not to swallow them? Did you hold a gun in your hand and then, your loved one walked in and stopped you from using it? So that it's very user friendly. And then it tells you what answers prompt a likely high risk situation, and it tells you what to do: seek further evaluation or get immediate help for the individual. This is available to everyone. And I'll point you to the Columbia Lighthouse Project here, which created this tool. and it has tons of information and screening tools in 100 languages. Um, that can be used by not just healthcare providers, but by teachers, by police peers, um, uh, faith community members. So I encourage you to take a look at that site. Now, especially at the Sinai CCE, we have a lot of responders who have worked or retired from law enforcement, which means that they generally have access to a gun. And we know that firearms are used in over 50% of suicides. So, a critical element of suicide risk management is what we call lethal means safety counseling. And what it essentially means is that if there's a person at risk for suicide, you ask them if they have access to a firearm or other means. They've been holding on to months worth of opiates that they haven't used, although obviously something like acetaminophen is quite lethal. Um, and if they do have a lethal means, you work with them and their support system to temporarily limit the access. And it's important to highlight the temporarily. Yeah, I've certainly encountered resistance from patients and law enforcement in limiting access. But I'll tell you, more often than not, I have experienced a sense of relief from them, from the patients, and from their loved ones, that there's something that can be done, that someone asked, that there's something that can be done that is temporary. And the important in this is that the peak suicide risk, where there is high intent, is something that can be very brief. Sometimes it lasts hours, sometimes it lasts days. So if you're able to put some space between the individual who has intense, who's at very high risk, and intent on killing themselves, and the means that they could use for killing themselves, especially a firearm, you can really reduce the incidence of suicide. So again, just kind of capture them at that moment of greatest risk and and keep them safe could make a tremendous difference. Other things that you can do in terms of suicide prevention are um, helping them coordinate care. Um, if there are case management services, which we do have in our program, use them. It's wonderful. Um, if you don't assist patients with connecting with treatment, do not just tell them, put in a referral for a psych consult or a therapist. That doesn't work. You really need to do more than that for your patients who are at risk. So help them connect with treatment, engage family in helping them connect with treatment. And also tell them, I'm going to give you a call next week or in 2 weeks just to check in and make sure that you were able to get that appointment or to see whether you're still taking the medication I prescribed to you today. Just check in on how you're doing. Yes, it's extra time and effort. It makes a huge difference. You'll feel good about it. Make sure that you provide crisis resources. The 988 Suicide and Crisis Lifeline is a great resource. It's there, free, confidential, 24/7. And one thing I encourage everyone to do is to just call the Lifeline yourself. Just call and say, "Hi, I'm Dr. Lowe. I'm a physician. I sometimes encounter patients who express suicidal thoughts. I wanted to give them this number, but I wanted to be able to tell them what to expect. They will be so happy to actually say, to talk to you about what patients can expect and what resources, what they can provide. It's a lot easier once you do it yourself to be able to then share this with your patients. It takes a few minutes. Please do so. Okay, so this is my last slide. In summary, I hope I have been able to give you some understanding of why depression is so pervasive in 2024. Essentially, the direct exposure to the trauma triggered a cascade of neurobiological and psychological events that have contributed to chronic illness in susceptible individuals. Again, most individuals are resilient. We know from research that this prevalence and persistence of depressive symptoms in our cohort varies and that it's mediated by the factors that I went into: comorbidity, occupation and training, downstream adversities, importantly, social support. I also hope that I have been able to highlight the important role that you all have in screening for depression and suicide, and some simple, effective things that you can do when faced with a patient with suicidal thoughts or intent. And remember that there is effective treatment available, whether you offer it or whether I offer it. Effective treatment is available, and let's make use of it. And I'll end with thanking all of you who take care of the responders and other workers who have varying traumas, and the responders and survivors who have contributed to our understanding by participating in research. So thank you all, and I am happy to take any questions.